Good morning. Can you hear me? Okie dokie. Well, welcome to you. Welcome to the ladies. Happy Thursday. Happy Tuesday. Tomorrow's Wednesday. That would mean today's Tuesday. And I am Carolyn, and this is Dr. Rosensweet, and we have part of Emily behind us. Sorry. Anyway, we also have, guess what? Questions. Yes, we do. Thank you, Dr. Rosensweet, so much. Question number one comes in. Question number one comes in like, how do you deal with life? Can we just talk about that? It's going to be, what the heck? Anyway, I'm going to fix this and speak at the same time. Question comes in, my funds are low right now, and I am wondering if I will get the benefit from the over-the-counter progesterone creams that I'm using, or the pharmacy brand progesterone that my insurance pays for, not the micronized compounded progesterone that I really would prefer. And I'm wondering what your feelings are on that. And please excuse me while I raise this.
Sure.
Honestly.
You might have to mute though, because we're getting an echo. Cost. Our team has done some research into the barriers for women to be treated in menopause with compounded bioidentical hormones. And so I'm going to have a lot to say about that because it's the most important thing that we have going on currently. And it's hopefully about to be deployed. We'll see. And so I want to cut right to that chase. There's a good chance, you never can totally celebrate until the ink is drying on the contract. But because of our national exposure and the number of participants we have, we've been negotiating with a national pharmacy, compounding pharmacy. And it looks like we're going to be able to offer all 4 ovarian hormones for $129 a month and maybe even less. We're learning as we go. And I think we're a month or 2 away from that being real. Although my team, my precious partners who are so astounding, they're going forward at an Olympic level of action. And that's all 4 ovarian hormones. So it's not only your bioidentical progesterone, whether it's in topical, you apply it to your skin form, or whether it's in oral micronized capsules, or it's the topical biased and the topical testosterone, or the testosterone combined with the DHEA or the oral DHEA. Whatever the 4 ovarian hormones are, customized and individualized to each individual woman, this price is liable to get really interesting. Now, what you can do now, I don't know enough about you to really be able to accurately answer the question, but over-the-counter progesterone is 18 milligrams per milliliter, 1.8% usually, and there's value in that, especially in the perimenopause. Women in their 30s, women in their 40s, and they're losing their progesterone faster than they are their estrogen. That topical over-the-counter progesterone can do a lot of good. And if the only tool I had was the pharmaceutical manufactured Prometrium, which comes in 100 milligrams oral micronized progesterone, or 200 milligrams per milliliter. I'm sorry, 200 milligrams or 100 milligrams. It's not solution or suspension. I would use that tool, absolutely. And 100 milligrams is a fairly average dose. And if your insurance will pay for it, that might be a better choice depending on how deficient you are in progesterone. I definitely prefer the compounded bioidentical hormone, the compounded. And we customize it, we individualize it to every individual woman. We give her a bottle of 50 milligram progesterone capsules. and a bottle of 25 milligram progesterone capsules. And we gradually increase. We start with 50 milligrams at sleep time, seeing if it helps a woman sleep. And in a couple nights, if she doesn't quite notice a difference, we increase it to 75 for 3 nights. Then we increase it to 100 milligrams. And with those 2 different dosage strengths, you can see that it's pretty easy to do the math. Kitty cat, kitty cat. And it's fun. It's fine. It's funny. They have a right to do their thing too.
Do they? I don't know about that today.
or they sort of, I think from their worldview, they may think we have a right to do somewhat of what we do. Their orientation is different. So, and we keep on increasing until a woman takes so much micronized progesterone at night that she wakes up groggy, obvious overdose, because progesterone's the great calmer. So if you wake up too calm, like you took an overdose of a sleeping pill, you've gone over the top. So then we back down. So let's say at 200 milligrams oral at night, she wakes up the next morning feeling drunk or groggy or drugged. 200 is too much. We back her down to 175, and that becomes her steady dose. And so the offering of 100 milligrams and 200 milligrams is not sufficient, because we have women who vary from 50 milligrams a night to 300 milligrams a night. And the most common dosages, I'd say, are between 100 and 150. So we want to customize that. But listen, if that's what you can afford, that's a good thing. That 100 milligrams or 200 milligram progesterone, go for it. And yet, any woman in menopause, progesterone is only one of 4 hormones that are imperative. Estrogen is imperative. Every woman loses her estrogen just tremendously.
You know, I have that question in here. I don't know how psychic you've become. You never miss a beat, because that's right in here.
Before we go to that, though, every woman also needs testosterone. There's no exception. Maybe some women, a small number, and smaller number of women don't need testosterone right away in the perimenopause or the early menopause, but within 3 years of no period, every 100% of women need testosterone as much as they almost need oxygen and water. Because without the testosterone, you lose your muscles. You get something called sarcopenia, and that's what leads women to canes and walkers and wheelchairs, and to adult diapers. That's part of how they wind up in adult diapers and get incontinent of urine. So all 4 of these hormones really matter. Progesterone's great, but progesterone was not the only loss. All 4 of those hormones are lost. And very often we attend to thyroid as well, because functional hypothyroidism is epidemic in the planet Earth, in the peoples. And so...
And the kitties too?
I don't know.
I've always wondered that, like whales, mammals, primates.
Probably.
Yeah.
Probably.
Yeah.
I mean, how do they slow down, and how do they get, not as vital and active and sleep more and get more feeble? It's probably the same thing.
It's interesting. It is.
Veterinarians, it'd be interesting. Veterinary medicine is fascinating, and it teaches us a lot about human medicine too. But at any rate, yeah, get that progesterone, get what you can get, and stay tuned to the menopause method. And because hopefully in a month or 2, we'll have this available to all Americans, and we're moving to Canada. We're getting it into Canada and to hopefully the EU and Britain. So we're working on it. We have a big team going for it.
Yes, and I get to be a small part of that team, and I love it. So I put it out on the Ins and Outs of Menopause page. It's a minute I get the green light.
Yeah,
wow.
great. Yeah.
Cats or no cats, it doesn't matter. I'll stand there on the rooftop, you know? How about Greece? She says. Yes, and Greece
Well,
too.
every place, every woman on earth matters. And we're also in negotiations with a distributor that is present in many, many countries in the world. And I was in Greece when I was 20. And I wound up on an island called Paros. I was such an arrogant young man. I knew that Mykonos was touristy even in 1962. So, in my arrogant way, I said to the ticket master of the ferries that traveled there, I said, I'd like the next stop after Mykonos. I probably missed a jewel of the Aegean or the Mediterranean and bypassing Mykonos, where there was probably so many fantastic people. But I enjoyed Paros greatly. Paros was special.
I was in Zakynthos, and very short side note, ended up having a moped accident, got into a hospital where they didn't have an
Oh,
x-ray machine, but they
wow.
had a goat in the back, and I healed. Whatever. It was beautiful. But we so often, Dr. Rosensweet, talk about progesterone, and I have another progesterone question, which you did just touch on. This woman has two doctors. And that's not really unusual these days. Her progesterone via the 24-hour urine, which is what you advocate for all the time, her progesterone is at 300. One doctor has absolutely no concern with this. The other doctor, however, is very concerned with this due to the possible health of her uterus and her endometrial lining. And she's a little confused. And she was wondering what your thoughts might be on this, if you don't mind elaborating.
Yeah, yet another of the millionth great questions. Um, we think of this topic called progesterone, but in any topic in menopause and any topic in medicine, there are so many intimately integral, related, moving parts. And we have to look at it from many different viewpoints. Really, what the goal is, what is the optimal amount of progesterone? And really, the goal is more than that. It's really what is the optimal amount of progesterone for the individual woman we're talking about. So the process to make such a profound determination like that has many discovery parts. And one of them is in our world, is the initial medical history. It's online, it's on an app, it's 12 pages if you translate it into pages, although who knows what pages are these days. They're just a scroll place on some computer or cell phone. And any physician or nurse practitioner or prescribing compounding pharmacist or PA who really has taken this on is going to go line item by line item by line item and learn a lot. And there's a lot of relevant things to a woman in menopause. And it goes way beyond progesterone. And progesterone is a key piece. So I always look at it from the global lens of who is this individual woman sitting in front of me? And we focus in on the ovarian and thyroid hormones. What's going on here? How does this relate to her total health needs? And we address it all. And that first year of addressing it all is a 4 to 12 hour process. And thereafter, once a woman's dialed in, it's an hour a year. 2 hours at the most. But why I'm mentioning the time there, because we look at a lot of different things that matter. And we look at it from a health perspective. We look at it as what supports a woman's mood, what supports a woman's sleep, what supports a woman's libido, her muscle strength, her vagina, the health of her vagina, her bones, her arteries. We're looking at all those things. And the health of her breasts, sort of a bottom line there. We want to do everything we can to prevent adversities there. And there's more. So in evaluating a patient, we're looking at it from the lens of how many things matter, how many things are related to the hormones, how do we dial in the hormones, and what assessments really matter for the woman that are focused on her menopause. I no longer try and be a global functional medicine doctor. Our program is focused on the hormonal changes and everything that relates to it. So another way to look at a woman, well, how's she sleeping? How's her mood? How's her bones? How's her muscles? And we evaluate all these things. How's the health of her breasts? And so when you're talking about evaluating any given hormone, to mention only the 24-hour urine, bless your heart for mentioning the 24-hour urine hormone test, although the word 300 tells me
You froze, and I can't hear you. I'm hoping that Dr. Rosensweet will be back. Small issue. So we'll give it a sec, see if Dr. Rosensweet will come back, which I believe he will. Either I'm going to stay here and see if he comes back, or I'll just go ahead and go back to the link. So hi, Levon, I see you, and I'm reading your question. Give me a sec. Let's see if I can run around the world and find Dr. Rosensweet again. Hang on, you guys, hang on. Come back up, all right? I'm going to go ahead and try and get back with you. Up.
And you might have to mute because we had an echo there. And I know where we froze. So I was talking about the 24-hour urine result of 300. And one of two things could have been happening there. One is that she could have been taking topical, and she could have done the proper way of collecting for a 24-hour urine hormone test is you take your hormones exactly as you've been doing solidly, religiously for a week before and the day of collection.
It's a week before?
Well, what we're looking for is we want a woman who's taking her dosages daily and not missing dosages. We don't want to test her when she's missing dosages. And we certainly don't want to test her if she's not taking her hormones religiously the week before and the 24 hours of collection. We want to measure the hormones as they're taking place in her body. So that number 300 is most consistent with she was taking topical, and she was taking it during the 24-hour urine hormone collection. That's what the number 300 tells me. But there's other things I don't know. She could have done what some laboratories suggest in their instructions, is that they're taking oral hormones to omit those hormones the night before and the day of collection. 300 in that case would be consistent with an oral dose when omitted that's very low. I'd have to guess 20 to 40 milligrams. That's very unlikely for her to be doing that. So I'm going to go back with my guess that her 300 was from a topical and that she did apply it. Well, that's one moving part that relates to proper progesterone dose. But there's other critical moving parts. Progesterone is so influential in mood that we're going to want to inquire with an inquiring, quote, microscope, metaphorically, end quote, to see how is your mood doing for you. You got any anxiety? You have any depression? You know, and progesterone has so much to do with sleep that we're going to want to really hear the story of how a woman sleeps. Well, so does estrogen, but and other things have to do with sleep. So in evaluating whether the dose that the woman is on, we want to evaluate that, and we want to know what her bone mineral density is. In the ultimate design of progesterone dose, which I love to get to its utter maximum, progesterone is the only biochemical that helps lay down new bone. It's the only influence to the osteoblasts, the cells that actually lay down new bone. So any woman who's got osteoporosis, we get a heck of a lot more vigorous with that progesterone. In that case, we're going to push that progesterone at night, at sleep time, until a woman wakes up groggy in the morning, i.e. overdose of progesterone. Yeah, just, you know, if you order to understand that, if you'll just watch Carolyn, she's charading out the answers.
I took my progesterone this morning. No, I'm just kidding. But I'll charade them out. Yes, happily.
We got that echo going. I just don't understand why, but we do. So you have to mute in between things. So we really want to know the health of the bones. We want to know the quality of sleep, the quality of mood. Those are two, the quality of the mood during the day. A lot of women they've never really been anxious their young life. Yes, we all have challenges. Yes, we all are emotional. That's healthy. That's normal. That's human. I love emotions. But if a woman says, you know, I wouldn't really say that I had anxiety when I was in my 20s and 30s. I had the normal challenges of life, and now I'm in my 50s and I'm anxious. I've got anxiety. This word that's a parameter to really look carefully at progesterone and see if we can really impact that. And there's even stronger disorienting moods. I'm here today because of Deborah, who slammed into my office and said, "Look, I'm going crazy." And we gave her some progesterone, and 3 weeks later I got a letter, because this was back in the day. I would like to report that it wasn't delivered by the Pony Express. We had the United States Post Office back. Deborah was communicating with me. Carolyn, you're just doing a phenomenal job of acting out these answers. It's like, it's wonderful for the hearing compromised. I always love watching the hearing compromised signing. I had a dear friend, a midwife that I worked with for years. Bless your heart, Crystal, if you're still out there, whose daughter wasn't able to hear, and Crystal was constantly signing her, and I just was fascinated by this. And, you know, of course, in speeches in proper America, you have someone signing if there's an important thing. Well, you look like that person today. With your
because I'm muted. I gotta act it out some way, right?
So I'm sure I was talking about something there, and I'm going to be able to remember it.
You were talking about something.
Yes.
I'm not sure what, but we were talking about progesterone. And, you know, just to say, like, questions come up. Does it always have to be an oral form? Another question says, I'm feeling, or statement, and Levon had a hard time, but she said, I'm taking 40 milligrams rectal suppository. Can I hire it? Progesterone's, I'll be quiet.
We have a major microphone issue. I'm going to see if I can correct it. So I do know where I left off there, and it was around that 24-hour urine hormone test. Now, the 24-hour urine hormone test is phenomenally accurate, and I say 100% essential, mandatory for the evaluation of estrogen levels in a woman who's being treated with topical estrogen, topical. That means you apply it to your skin. And also topical testosterone. It's mandatory to apply testosterone topically. And the 24-hour urine is phenomenal for that. And the 24-hour urine is phenomenally accurate for topical progesterone. But the 24-hour urine, in fact, any test method, just doesn't work well for an orally taken steroid hormone. Because you swallow that capsule and that goes into your small intestine, and it travels from the small intestine where it's absorbed to the liver directly. Before it even has a chance to circulate to the entire body, it goes directly from the intestine to the liver, and somewhere between 70 and 90% of that progesterone that arrives in the liver is converted metabolically to something called metabolites, and in the case of progesterone, it's pregnenolone. And how we indirectly measure progesterone levels if someone is taking oral progesterone is by assessing pregnenolone levels, because the liver is so efficient in biochemically transforming progesterone. Maybe 10%, maybe 15% of the progesterone you swallow actually goes to the whole body because it makes it through and doesn't get metabolically byprocessed right away. This is called first pass through the liver. And so when you're taking progesterone orally, the 24-hour urine hormone test does not help us, nor does any other test. Because we're measuring, progesterone is so efficiently metabolized that we're measuring the metabolite to assess the progesterone levels, and you can get super high progesterone levels, pregnenolone levels. So 24-hour urine is great for assessing topical progesterone. And we can get a ballpark amount if we on progesterone, but only ballpark. We could only make a guess. So we rely on these other ways to evaluate progesterone. In a woman who's having sleep disorder, a woman who's having anxiety, one of the ways we're assessing the progesterone dose is, are we getting improvement here? And we go to the bone mineral density. If there's osteopenia, that means some bone loss. And we also go on to assess whether that bone loss is active. If we see osteopenia or osteoporosis, we do a urine, it's called deoxypyridinolone. It's a bone metabolite. We measure the amount of bone metabolite in the urine. There's always a certain amount of metabolite of bone in the urine because the bone is active metabolically. People don't think of that, but there's new bone being laid down all the time, and old bone is being taken down and recycled all the time. And one of the chemicals related to that bone breakdown is deoxypyridinolone. And a certain amount is always going to show up in the urine, but if too much shows up in the urine, more than is in the reference range, that woman is actively losing bone. Why am I saying this? Because the 24-hour urine is critical part of, and not the only part, in assessing topical estrogen levels and testosterone levels and DHEA levels and corticosteroid levels. But if a woman's taking oral progesterone, we don't get an accurate reflection. we get a guesstimate. So we don't rely on just the 24-hour urine as a measure of whether the woman's on an adequate progesterone dose. And it depends on how much we want to push the progesterone. Some women, they can barely tolerate progesterone. It's a real challenge to get a few milligrams into them. Other women, they need 300 milligrams of oral progesterone. That's not the most common things, but it gives you an idea of the range. So there's many ways to assess progesterone. And really, it explodes us into how global an assessment, treatment, and evaluation of treatment process is to properly individualize this for women, which is why the menopause method we developed what we consider to be standard of care, and we're trying to achieve board certification for a specialty called menopause, because there's a lot of moving parts. I don't want to make it sound too complicated. Back in the day, when I first got into this, 18 million American women were on 1 or 2 doses of Premarin or Prempro. They go to their doctor, they were in menopause, they were given oral horse urine-derived estrogen, Premarin, and Prempro, a combination with a progestin, and you know what? Those women did so much better and were at less risk for breast cancer, heart attack, and stroke than women who were not treated with hormones. There's a story in there. Why would I say that? Aren't we supposed to be scared? No, the opposite was always true. There was never an increased risk. So, and there was no way to test Premarin. There was no tests. There was no blood tests or 24-hour urine hormone tests. This is horse urine-derived estrogen. No one went to the trouble of developing a test, nor did anyone feel like they needed to. So I don't want to make this overly complicated. You get some estrogen, and you get some testosterone, you get some progesterone, you get some DHEA. And if you get it, you're way ahead of everyone else. And if you get it right, that you're even more ahead of it. Because I don't want to make this, yeah, that's right. Carolyn. That's the important thing. You start off by getting yourself some estrogen, progesterone, testosterone, and DHEA. Now, we can fine-tune it from there, but I met many patients who came to me. I can remember one very distinctly. She had a hysterectomy when she was 20. I'm sorry, when she was 40. She came to me when she was 60. She had been on Premarin for 20 years. And that woman looked good, and she felt good. She didn't come to me because she was in duress. She just got fascinated by the concept of compounded bioidentical hormones and wanted to check them out. Why am I telling you this? Because I am a tremendous lover of getting excellent and precise and using the best stuff available on the planet Earth, which is compounded bioidentical hormones, and have your program be developed and monitored by a physician or nurse practitioner or a physician's assistant or prescribing compounding pharmacist that really knows what they're doing. And that's when you get into the 24-hour urine hormone test. And of course, I'm the world's one of the strongest advocates on the planet Earth of this thorough process. And we have a 12-hour training program. We have a mentoring program. We have grand rounds. We have exams. We got the whole 9 yards. We have apps. We have every part that can be automated and that can be an internet technology function. We're doing it. I got a team to back us up because I've been doing this for 25 years. But what I really want to say about that is please don't be overwhelmed. Please get yourself some hormones, male and female. However you get them, they're going to do you good. And they don't have to be dialed in perfectly. And that's why I wanted to give you the example of that Premarin and Prempro. I've never written a prescription for Premarin or Prempro in my life. But women who that's all they have, there was 18 million American women on Premarin and Prempro in 2002, before everyone got falsely scared. That was 40% of all American women in menopause were on Premarin or Prempro. And bless your hearts, these women benefited enormously And the only tragedy was they got scared. So even though I'm such a fan of getting excellent in this, and that's what we do, I also want to put a shout out to get you some hormones, whatever you can get. And if we can serve you through the menopause method, compounded bioidentical and the organic oils with the precise mechanism that we process that we describe in the book that Carolyn's got posted in Ins and Outs of Menopause called Happy Healthy Hormones, all the more power to you. And if you don't have access to that, it's okay. You can do great work by getting the hormones for you. Just find someone who says, yeah, I deal with menopause and hormones. The chances are you're going to be way, way ahead of the game. You're going to be doing something good for your body with whatever you're prescribed.
So
I don't want people to be swept away by, oh, this is so complex. I can't possibly do this and I can't possibly afford it. And my own insurance only pays for this. So therefore, I'm going to be disappointed. I want to antidote that concern. You get yourself some hormones by someone who can prescribe them. That means they know something. And you're going to do good and be on them for your whole life. And you're going to do good, testing or no testing. The North American Menopause Society and the American College of Gynecology, they have white papers year after year after year. They say, don't test a woman in menopause, just go by symptoms. Now, they're referring to the blood test and the saliva test, and they're accurate. They're right on. These are not adequate tools for assessing hormone levels. And what they're also saying is you can go by symptoms and do a lot of good. And I say they're right. Yes, we go the full 9 yards. We do it. But I want you to get comfortable with wherever you can land in the process of being treated. If you've got someone who can write the prescription, has got some training, and they give you whatever they give you, celebrate it. Embrace it like manna from heaven. It's going to do you a lot of good. And you can be on it for your whole life. And they're going to monitor your breasts with proper mammography. And they may even monitor your uterine lining. That was the other thing around progesterone, by the way. If you don't have enough progesterone, you're going to get too thick of a uterine lining, and you may bleed or you may spot. So we do a transvaginal ultrasound, and we prescribe a transvaginal ultrasound. We want you to get to the gynecologist who does these in their offices. But I don't want to digress from it. I got really excited, you can tell, Carolyn. I'm an advocate of getting women on hormones with someone who cares about the subject and has got some tools. They're going to put you on hormones, and they're going to be good for you. And yes, if you can find your way to the menopause method, or we've got a new name coming up here called Bright Live, Brite, Bright, that's great. But all of it's good. And you don't even have to test. And mistakes can be made. You can get on too much or too little. But I've probably overdriven my point home.
Well, not really. I mean, am I echoing really badly? Can you understand my question?
Yes, I can. So we're gonna receive the question as it coming in on an echo.
Maybe I'll get a cue card.
So when you talk slower like that, it echoes 3 times, but it's receivable.
Maybe I'll get a cue card. Women says I cannot tolerate estrogen. I've tried gel, patches, pills, sprays, everything. I do really well with progesterone and testosterone. Am I okay with just taking progesterone and testosterone and not any estrogen? Kind of piggybacking on what you just said.
It's a couple ways to look at it. It's the power of individualizing. We cannot lay down these rules and say women must have estrogen, must have progesterone, must have testosterone, and must have DHEA. We don't approach things like that. We approach it for trying to sort out what's the individual woman's proper amount of each hormone, and it could be 0. There's some women, the proper amount for their body of progesterone is 0. They just can't tolerate it. And so we individualize it. So this woman has done some work and is coming up with something that my guess is serving her. Bravo. Being on progesterone and testosterone is terrific. Now, I do challenge you, though, because I've never seen a woman who didn't need estrogen. I have a skewed view on the world. I mean, these are women seeking out professional help for menopause. So that's a certain demographic there. And that's 25 years of treating women in menopause. I've never run into a woman who didn't tolerate estrogen. I have run into 1 or 2 women that didn't tolerate progesterone or tolerated so little. Yeah. I've never run into a woman who didn't tolerate estrogen. So my challenge to you is the due diligence at a level of massive expertise being done to see what's going on there? And yes,
She's not here. She's in Europe, but she's with us every interview.
yes. And so there's some more things that I know. A woman who is like has a tremendous amount of adipose or fat tissue, there could be a biochemical way that she's taking the testosterone and converting it to estrogen. Why I say a lot of fatty tissue, because testosterone can be converted to estrogen in the adipose tissue or fat tissue, and it is stored there, and it can be converted. So we don't know what her estrogen levels are, but she didn't mention her weight. This is not occurring in thin women. They just don't have the adipose tissue to be the reservoir where the biochemical conversion can actually take place. So there's some missing information here. But one thing about this woman, and every woman who's ever menstruated in her life or has breasts, you had robust levels of estrogen sometime. So there's some mystery going on as to why you're not tolerating it right now. And it might be you're on too much testosterone, and I don't know, because if you're on too much testosterone, your body's going to have to come up with some protective mechanisms, and that testosterone can convert to estradiol. So these are the kind of cases that are big fun for me. I mean, I call this entertainment. For those of you who have some sport or hobby that really captured your attention, man, sock it to me. Give me this case. I'd love to help this person unravel it, because there was a time in your life that your body had robust levels of estrogen. So for you to make a statement, I don't tolerate estrogen, I challenge that. It could be the wrong estrogen. It could be there's too much testosterone. So you just can't. There could be some major imbalance going on there. There could be you're not using the proper dosages. So I'm not going to just agree right away that your body does not tolerate estrogen. I really challenge you there. And so it might be that you're doing the best you can, and good going. These 2 hormones are going to serve you greatly, testosterone and progesterone. And did I hear DHEA as well? Got to know what those DHEA levels are. You can run into this.
You didn't hear it, but boy, you are a smart man. Yes, you are. Can you understand me? She says, yes, her body totally does not seem to mind. PNT, DHA does not seem to like, no, her body doesn't like DHEA either.
Okay, well, I'm still going to say I challenge this patient And it may be she's on the best program that she can possibly do, and bravo, she got some good stuff that are going to serve her. And it might even be her testosterone is converting to estrogen, so her body doesn't want any more estrogen. I don't know. I don't know what her dosages are. I don't know what her 24-hour urine hormone test looks like. But I'm going to challenge her to find someone who really knows what they're doing. And in Europe, you might want to contact Dr. Terry Hertog, Hertogue, Thierry. He's in Belgium. This is a world expert. They do 24-hour urines. And he's got a clinic in Belgium, and he's been around for so long. He's so connected to European physicians. I'm sure he teaches them. He's a major teacher of European and American physicians. He comes over to America at least once a year and teaches for the largest organization in
Well,
America.
that's kind of like you, sort of.
Well, yes, well, she's in Europe, and she could, if she needs, but someone of Dr. Hertog's, and that's Hertogue, I believe, or Ghete. It's Hertog. Hertog. There's an HE or something on it.
Could be a GUE, HERTOGUE, because if it's TH, yeah.
I can look it up, and I'll look it up right now while we're talking. And the main thing is, there are so many instances where it calls for the expert. Like when I want to tell you, when I have a medical issue, because I'm a medical doctor, I am going to seek out the best of the best and see if I can get in to see him. Because I know how many technical issues are involved in anything medical. And it may not even be a medical doctor. It may be a chiropractor. It may be a nutritionist that I'll go to. It may be a massage therapist. There's all kinds of health care providers. So I'm going to choose the right ones, and I'm definitely going to try and find someone who's right up at the top tier. And because there's so many times, and I say this woman is a classic example of it. She needs top tier evaluation, because I don't initially accept she could be right, but I'm still going to say she might not be. And I would only accept her conclusion about she doesn't tolerate estrogen after someone who really knows what they're doing, like Dr. Hertog, for example, in Europe. So they evaluated the medical situation, and they. So I think I'm looking it up right now to get the spelling right. It's Dr. TH. I'll put it in the chat. Carolyn, can you work with that?
I won't see it, but other women will.
Oh, okay. I'm going to put this in the chat because this is for the Europeans. God bless Europe.
Oh, indeed, huh? Yeah. Thank you.
So there it is, everybody. That's in Europe. That's I would try and connect with Dr. Hertog. Their clinic is going to know how to proceed.
Thank you so much. And especially for that name is huge, I believe. This is going to be very, very helpful, and I really appreciate that. Marita.
One other thing. I have a hard stop at 5 minutes to the hour, as I have another live interview to be.
Well, okay. That is just okay.
And meeting, you've got some commitments this coming Thursday, so we won't be meeting on Thursday. Would you tell us? Well, I'm going to say it because Carolyn, your echo is really intense. I'm going to say it. It's we won't have our usual Facebook Live this Thursday and this coming Tuesday, and we'll resume 1 week from this Thursday in our customary Facebook Live. Carolyn is getting a very much deserved fun trip.
Well,
And education. I know there's an education component to it.
it ain't easy. My echo, I'm so sorry. Apparently, women are saying I'm not echoing to them, but I am to you. It's weird.
Glad that they're not. That's fantastic. So it's me.
Yeah. So I hope you can understand this, and we have like 3 minutes. I don't even want to present this, to be honest with you, because it has to do with hair. And when
Let's pick one for next Thursday.
yeah, it's a biggie, and it has to do with estrogen and not tolerating all of that kind of stuff. So maybe we can kind of like wrap it up now, so that we'll give ourselves. Ooh, I'm hearing myself.
We could answer that progesterone question from Michelle. What are the levels for menopausal women for 24-hour urine hormone test? The levels are going to be on the low end on a 24-hour urine hormone test if you're doing topical progesterone, because we just can't get topical progesterone strong enough and still have it absorb. So a lot of women do well with topical progesterone. We always start off every woman on topical progesterone, but very often we'll convert to oral. Once you're doing 24-hour urine tests for oral, or any test for oral, you're in a whole new different world, because we're dealing with that first pass through the liver. So we do multiple things to assess progesterone levels. Number one, are you sleeping well? Number two, how's your mood? How's your bone density? And how's your uterine lining? Do you have enough progesterone to suppress the development of the ovary, to balance estrogen and suppress the formation of a uterine lining so you do not bleed? And that really matters. And so we do transvaginal ultrasound when in doubt. And to cut to the chase, we start low on progesterone, whether it's topical or whether it's oral, and we jack it up until a woman goes into overdose symptoms. They're listed in our book, Happy Healthy Hormones. And then we back it down a little bit. We like to maximize progesterone for a lot of reasons. It's so good for you. I'm going to need to sign off, Carolyn. Bye, everybody. We'll see you in a week from this Thursday.